Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to episode number 126 of Tough to Treat. And if you're listening to us when this comes out, hopefully it's not in 100 degrees where you are, because it's certainly 100 degrees where I am in New York City still. It's pretty hot. But a quick intro into this episode. First of all, Susan and I still, really want to hear from you. So please, go into our website, toughtotreat.com. And, we've got a lot of great PDFs, clinical pearl PDFs to share with you, as well as some persistent pain and sleep tips. It's a wealth of knowledge in there. And if you have, for all of our listeners, if you have any questions about certain regions of the body or any topic or any keywords you want to put in, you can just go into our Tough to Treat website and go under the search function and type in nerve pain or hypermobility. And there'll be several podcasts devoted to those topics. So the keyword will either be in the title or they will be in the description. So that is toughtotreat.supercast. Oh, excuse me, that's toughtotreat.com. And Susan, do you want to talk about the membership, or should I?
Yeah, sure. Absolutely. And so don't forget, we have our subscription membership program, the podcast club, which is Tough to Treat on steroids. And you get not only the podcast dropped into your feed, but you get our special podcasts. And we've got some people lined up that we're interviewing this summer that will be coming out. And we have an Ask Us Anything portal where you can drop in any questions you may have, any thoughts, comments, and we come back in and answer those. Also, it's important to know that we offer a live Ask Us Anything session every month. And that's basically a chance for you to come in for the cost of the membership and talk to Erica and I and get our opinions, help, mentoring, whatever it is that you would like to have. Can't beat that price anywhere on the planet.
I know,
So,
especially, no.
Yeah, join us.
Yeah, especially if you have a burning question,
Yep.
That's how you're going to get your answers quickly.
Right, so we hope everybody's having a great summer 2022, and we hope you enjoy the podcast. Thank you.
Hi, everybody. Welcome to episode number 126 of Tough to Treat. This is Erica Mello, and I'm with my wonderful co-host, Susan Clinton. How are you, Susan?
I'm good. How are you?
I am good. Let's get...
It's not 100 degrees here. I'm sorry it is in the city.
Oh, I know. My God. I was walking home the other day, and I swear to you, it was 95, and it was about to rain. And of course, it didn't rain because it would have cooled it off. The air was so thick. I was like, oh my God, I made it maybe 15 blocks and I had to hop on the subway. I couldn't take it. It was brutal.
Yeah, we've been about, I hate to say it, but we've been about 78, 79 in northern Michigan.
Oh my God.
So
that's fantastic. I love it. Yeah, thank God for air conditioning. So let's just get to this. This is a patient we have talked about, specifically headaches or, a lot of neck. We talked about neck pain, but not specifically headaches. And so I wanted to talk about a patient that I've seen and sort of do a little bit more of a deeper dive, not into the diagnosis, but exercise progression with people who have headaches, right? Or who have neck pain associated with headaches. So I'll just give you, Susan, and everybody a quick history, and then we can just sort of talk about how we would progress this patient going further, because the last thing you need with patients is they come in for 3 visits, they're good to go, and then they come back again because, number one, they just feel better and they feel that they don't need to come back and have a quote unquote exercise progression. But I think a lot of them do. So let me get you started. So he's probably in his mid 40s. So this guy, I didn't have exactly his address right here on the piece of paper, but mid 40s. He is a designer. He designs exhibitions. So a lot of sort of computer generated work, but he actually is in the physical location designing art exhibits. So moving his hands and his arms. He only wears glasses when he uses his laptop, similar to myself, right? 1 month prior to the initial assessment, he had bilateral sort of headaches. And so he pointed across his occipital condyles and just went across the back of his neck. And then some radiating pain into his right shoulder blade. I'm sorry, left shoulder blade. And he prefaced that. So just hold those symptoms. I did send out the CSI questionnaire. Okay. And I'm just going to throw these out. The score, not relevant. I mean, relevant, but I want to talk about the often and always with him. So we have never, rarely, sometimes, often, and always on the questionnaire. His offens are, I feel unrefreshed when I wake up in the morning. My muscles feel stiff and achy. I get tired very easily when I'm physically active. Those were offens. Always, I have headaches. Often, I do not sleep well. Often, stress makes my physical symptoms get worse. Always, I have muscle tension in my neck and shoulders. Often, I have to urinate frequently. And his B, CSIB, the chronic fatigue, he said doctors haven't diagnosed it, but he's quite fatigued. Migraine or tension, yes, obviously. Neck injury, anxiety or panic attacks, he has anxiety. So he was positive on the CSIB and probably somewhat. The often and always are kind of, for me, sort of interesting to see. So that's the backdrop. Okay.
I just want to point this out for our listeners because I get a lot of questions, comments, sometimes a lot of pushback about the involvement of the upper cervical area with urinary frequency, urgency. And here we go. This was not his primary complaint.
No.
But we get a lot of people. This is why it's important to look at the whole person. Not just if they come in with urgency frequency and blame the pelvic floor muscles, that we need to look at the system. And you need to look at these things: sleep, stiff, achy muscle tension, headache, stress. All, they tie in. This is a ramped up sympathetic nervous system person.
Yeah, totally.
Awesome.
Exactly.
Thank you for bringing that CSI thing up because we haven't talked about it in a while.
We haven't actually. Yeah. We haven't. Yeah. And his DAS was kind of unremarkable. I mean, those are not really remarkable, to be quite honest. I mean, your usual stress things, but nothing like no major 2s or 3s. Okay. On that. So, so he has some sort of medical history. He does suffer from tinnitus in his right ear of 2 years onset. So probably just before the pandemic. Tinnitus. He also has a CPAP machine for sleep apnea. He's had for years. Okay. Let me see any other medical history that I need to make you guys aware. I'm just looking through here. Okay. So no concussion, no falls. He's right hand dominant. He's been on a statin for 3 years. He takes fish oils. He does, and it's really interesting. I saw him reason why he's a former patient of mine. I saw him for low back pain some years ago, and we fixed that, so to speak, and he was good to go. I hadn't seen him in many years, actually, and he's the husband of a patient of mine. So he did. Other than that, I circled the word fogginess on the initial evaluation because I think he had mentioned that he gets some fogginess occasionally as well. He does take an occasional Valium and occasional diclofenac. That's sort of his medical history. I thought the tinnitus, I don't know if you say tinnitus or tinnitus. I say tinnitus.
Depends on where you live, I think.
I think so, right? And the CPAP machine I thought also was interesting. He's in terms of stature, not real big, not small, but average-ish frame. I asked him about coughing and sneezing. I said, when you cough and sneeze, does that actually trigger a headache? He says, yes. He said, I feels more pressure in my head. That's the word he used than anything. And he's like, well, maybe, because I said, well, what do you think it is? Because I asked everybody, what do you think your problem is,
Exactly. One of the 3 questions.
Exactly. He's like, well, it could be my sinuses. And I'm like, okay, I don't judge, just write it down. And I said, do you get triggered by light? Because I do, because I suffer from headaches. He said, no. I said, do you get triggered by loud noises? No. Okay. And so it was mostly the pressure. It was pressure, Susan. It was like pressure in his head. Okay. And then the occasional referral into the shoulder blade. That was probably for just a neck issue. So, so the reason why I brought him up, and I can talk about what I did, from, I want to talk about an exercise progression. So what I ended up doing with him, hold on, I'm just going through my notes. we always talk about picking a functional movement to screen with him. And given the fact that he does bend down a lot and he does move his arms a lot and he's sitting at his computer, I did look at a couple movements. I just said, just squat with and raise your arms above your head. I just was curious to see how he moved. That took me 30 seconds at most. And, you know, he had some shifts and moves and translations, none of which I thought were relevant, to be quite frank. So I said, just stand for me and just stand and lift your arms up and down. I said, stand and lift your arms up and look down. Stand and lift your arms up and turn your head. Just, this is how you're moving, okay? And every time sort of when he looked down or when he turned, he felt pressure in his head, okay? Mm-hmm. So do you have any questions so far? Do you want me to keep going?
Was he standing when he did that?
I did it, but I did it in standing and sitting. Yeah.
Was it the same?
Standing.
Was it worse in sitting, better in sitting? Were they the same? I'm just kind of curious.
Well, no, it was actually worse in standing.
Interesting.
Yeah.
Okay.
Yeah, it was worse. Yeah,
it just, I was, you know, because my first thought is, I wonder if there's a dural piece to this. So
yes, right. And
the pressure makes sense with the sinuses and stuff.
Yeah.
You know, and definitely he doesn't have the typical migraine that, you know, has photophobia and, you know, all the sounds and things like that. But I do find it interesting that, yeah. So, okay.
He doesn't. Yeah, no. So I did that. And so I took a look at him in standing first, because I just had what I do. You know, just so where center of mass is, it was over to the left. Okay, fine. You know, I moved on from there. I did put my hands, you know, up in his head a little bit. I've done a little cranial work just to get a sense of some rhythm. I'm not going to go into that, you know, whole thing, but I just got a sense of where I learned a little bit of this from the Baral, some of the visceral classes, just got a sense of where his head was. I closed my eyes, put my hands like earmuffs around his ears, and just felt, this is just not a woo-woo thing, but it's just a sense of, I just want to get a sense of, to see where he was in terms of head movement, or if he was swaying when my hands were on his head. I just put some input there with manually, like I would correct a thorax, like, you know, decompressing the thorax or repositioning a foot. I just put my hands like earmuffs around his ears just to feel. No science, just nothing. That's what I did. Not a whole heck of a lot happened there. I did have him turn. I looked at him. I had him sit. I looked at his face, and I noticed that his right eye socket was very deep. I was like the big thing. It was like really deep. When you see something like that, if you want to go from the craniosacral world, okay, yes, does he have like a twist or torsion in the cranium? Probably, but you have twists or torsions in your thorax and your pelvis, and they're fine. But that's what I did notice about him. I had him read something. I said, just read, like, not like an optical chart, but just take a piece of paper. And I had like a magazine, and I said, read this. Just read that. And I said, note how that feels, how that is, what that does. He said, okay. And so I'm not going to talk about the whole eval, because I wanted to, his main driver was obviously in his head. Okay. It was his cranium, especially his O1 too. Okay. He had a lot of, you know, thoracic shifts, you know, in his upper ribs. He is a designer. He has to bend over. He has to move. But the overarching theme for me, at least based on the CSI questions and his narrative, he didn't have a huge chronological history of injuries, okay, like a lot of people do. So his driver was up in his head, his O1, his CO, C1, C2. I did do work in there. I'll talk about the treatment. I did work in there. I did some manual work in there. I did some eye tracking with him as well. But the reason why I wanted to talk about him is because of his job. When you have someone who comes in with headaches, because headaches are chronic, right? They're chronic. How do you give somebody exercise progression who suffers from this type of a headache? And you know, the manual input did help him. I mean, within 2 sessions, he was like, I'm good to go. I'm like, you need to come back for, you know, like I need to progress a little bit. Right. So, and I did just a lot of manual work in his neck, and I'm not going to go into that. But I wanted to get him him moving with exercise. I had an overball on like, you know, those little overballs where you lie on and you squish. I had him lie on that to see if he could have some neck control and head control, have him lift his legs up, lift his arms up, move his arms, but he was supine, not highly functional. Mm-hmm. I'm going to stop there, Susan, and I would like your input. or any
Yeah.
questions?
Yeah, you did like the manual work to get some, to help get some neural input into the muscles to get them to let go so they weren't guarding so
Yes.
much.
Yes.
And eye tracking, I think, is really important because of the cervical ocular reflex
Yes.
and make it, the eyes guide the neck,
Yes.
getting the eyes moving again. And
Hmm.
but I do think that we have to consider how do we, get this guy's capacity up to do his job. And I think that's kind of the idea behind the exercise progression is this is somebody who's been probably poorly adapting to his job for a very long time.
Yeah.
And he's got other problems in here. He doesn't sleep well. He's on a CPAP machine.
Hmm.
There's reasons for neck issues with him.
Yeah.
If even if it's just for that, he does take a Valium occasionally because this is, like I said before, this is somebody running with a pretty high sympathetic charged nervous system, and getting him to calm down is one thing, but also getting him the physical capacity to perhaps do his job better. So
Yes.
I'm excited to see where you're headed with some of the exercises. So I
Yeah.
like the head control supine first. It's a safe
On
place
the
to start
overball,
working.
right?
Yeah, it's
Yeah.
a safe place
Yeah.
to start working.
Yeah. And I thought of that. I was like, okay, let's start here because that's where I would start. And because let's see if you can maintain some head control on an overball is not horribly unstable, but it's not a hard table. And let's see if you can lift your arm up. Let's see if you can lift your legs up. Let's see if you can do things. Then I got him up into sitting, and I do have access to Pilates equipment. So I'll talk a little bit about that, but I know a lot of listeners don't have access to that. But you can sort of mimic Pilates exercises into real home exercise programs, but that's another episode. And so I knew in standing because he was worse in standing, right? With the use of the arms. And I said, how do you actually stand during the day when you're moving? Because the laptop issue was a problem, but that got better. Okay. And I do think knowing him and knowing his family, that stress is a significant component here. And I asked him how he managed his stress. Did he have time for exercise? How much do you literally have time to do? Because at one point he had to cancel an appointment last minute on me because things got crazy at work. And that says something to you about the person and their priorities, right? And we all have those times where we have to cancel things last minute, but this was not an emergency type thing, right? This was like, I'm really busy, I can't come. So that says to me that he's not prioritizing himself in a way, right? That's a little judgmental, but I know this person. So you need to be able to what's the word I'm looking for, Susan? You need to be able to impress upon, thank you, the importance of some consistency at the beginning of treatment, okay? This wasn't a typical patient of ours that comes in with 8 body regions lit up. No, this was a chronic headache. And so I have to be honest, chronic headaches are tough to treat. They really are, because they come back. And I'm a live prime example of that issue. I get them frequently. So, I think that with him, after I progressed him from the supine overball, because there's just so much I could do with an overball, I got him up and standing. And this is what I did. I played around with our normal, narrow, wide center of mass. Okay. I was like, okay, this guy can do a squat. Squats are very straightforward. They incorporate all the regions of the body, use your arms. So I just had him do a squat with a normal base of support, with a narrow, like his normal was a little bit wider than hips width. So he went wider than hips width, very narrow, and then wide, just to introduce variance in the system. I said, just do literally up and down, no weight, just do a squat, maintain head control. That's what I did, sort of from a functional full body movement. And then I had him also, because sometimes he said his neck gets a bit stiff. So I had him just in sitting and do those head on body, body on head rotations where you're, let's keep your head straight, tracking on the wall, look at the wall and just turn your trunk to the right and then turn your trunk to the left to get that superimposed rotation from below. And so I did give him those as almost like resets in a way. He wasn't that far along in terms of like treatment, that he was, jumping up and down and doing high level exercise, and that's not his nature. So I did give him those head on body, body on head things. In terms of eye tracking, Susan, for home, what do you do for people for home programs for that? Do you give them?
So for eye tracking, I like the clock yourself out.
Oh, that's right. Yes. That's right.
So I like the reactive piece of it.
Yeah.
Because it calls out, so you can, we've talked about this on the podcast before.
Yeah.
I also like doing things like, slowing some exercise down for him. Can you look before you reach? Can you look, can your eyes lead the way? So spot something, turn your head to it, spot something, turn your head to it, spot something, turn your head to it. Because what you're mentioning is this guy's got this fluid motion going all day long, and his eyes may not be leading the way. He may be overusing his head and arms and not doing a lot of good eye anticipatory kind of stuff.
Yeah.
And so it seems to me that perhaps maybe before he reaches, it's just an exercise to slow things down so his eyes can catch up.
Love it.
And so with his work, he could kind of just stop for a minute and just stand there and look at the different things without turning his head and his body. And then he can say, okay, now I'm looking up and I can reach up, and now I'm looking down and I can reach down, so that he can kind of pull the eyes back into it a little bit more. Something, he might find that to be kind of fun. I don't know. They might find it to be distracting, so they may have to do it at home in a different way,
No, I love that. I love that. And so, because the normal narrow wide is a great variance, but the looking with the eyes is another variance, another variability. Yeah. Oh, I like that.
Look with the eye before the head, rather than the head turning and the eyes not really going with it.
Yes.
Yes. So
that's fantastic. And the clock yourself. Yes, that's right.
And you can also progress the clock yourself and the looking, eyes spotting, moving while they're standing on like a Bosa ball.
Yes.
If you really wanted to or a foam mat or whatever it is that you want to challenge their balance with.
Yes. Yes.
So that can be good too.
Yes. And I do think that, so for him, yes, I eventually, for somebody like this, because he literally was like 4 visits, he's good. But I do think that I would have probably kept him for a couple more just to progress the exercise. So we're going to do an imaginary 5th and 6th visit for this guy. And I do think that, and if people were not good to go, I mean, obviously they'd still be coming, but I like the BOSU, and I would agree, could challenge the balance, the mechanoreceptors in the C-spine with something like that. That's a great one to do. What I also did give him, I actually had him take a TheraBand wrapped around his arms. And I just had him do the same squat with an arm lift with a TheraBand. And I actually did have him look up at his arms, look down, look up, look down. But I didn't have him do the leading thing. So I like that little nuance, leading with the eyes and not the head.
Yeah. And I think something else with the Bosa ball or the Swiss ball is seated.
Yeah.
This guy's got urinary frequency issues. The input through the pelvis and low back could be very nice for him, and the hips. To kind of like, how do you feel when you're on here? Can you bounce? Can you bounce up and down? Can you move around? Now let's do the arm exercises sitting on that kind of unstable, or more challenging surface, and the eye exercises too. So standing and sitting, I think for him would be pretty meaningful.
Yes. And they're not, for the listeners, the neck is, you don't need to, I mean, I have patients who come in from other places and they're like, oh, they made me do isometrics on my head. And I'm like, cringe when I hear that, but it's like, you don't necessarily need to do like neck movement. You need to think about what the neck controls. It controls a lot. Balance, the whole kit and caboodle, so to speak. So I do like the sitting on the Swiss ball.
It's
as
just
well.
It's a variance. It's a variance of body on head rather than head on body.
Right.
When you're working on those kinds of things, so you want the body to move under the head, and so that's a nice way to have that happen.
Yes, exactly. And for we could even take that further. You could, just superimposing doing. He wasn't a real big exerciser, but let's say his guy was, lunges onto a BOSU, lunges on and off a BOSU. Any exercise on and off a BOSU or sitting on a Swiss ball, I do agree. I think that's great ideas. So this guy did have a lot of issues with sleep. Okay. And there's something that would be another consult, you can tell them that they need to sleep better and give them, what do you want to call it, Susan, tools and tips for sleeping better. But a lot of people resign themselves to the fact that they don't sleep well and they don't do anything about
Yeah.
it, you know?
Yeah. And the guy, he's wearing a CPAP, but he can still wear something over his ears. I'm just wondering what he would like. Does he like meditation type voices? Does he like sleep music that is designed to have the right frequency to help people go to sleep? What
Mhm.
is it that he needs? Is he waking up in the middle of the night because he has to go to the bathroom 4 times? I would really like to
Yes.
unpack that with him and find out what's really going on with sleep, and really ask some questions. What time is he getting to bed? What's he doing before bed? What's all, just the whole thing around it, to see kind of what's happening there.
Yeah. I think every one of my patients who gets up in the middle of the night has to go to the bathroom. I don't know one who doesn't. Like every
Right.
single, right?
Well, so 1 time for an adult is normal. More than one
Mm-hmm.
time is not normal. So there's considerations there that need to take place. And with him, I'm just wondering if he doesn't drink all day long because he's got this urgency frequency, and then he drinks in the evening,
Mm,
hydrates later when he's like home and can go to the bathroom more.
yeah.
I don't know what his blood pressure may be rising at nighttime. This guy's got stress and he's on a CPAP.
Yes.
Sometimes a rising blood pressure at nighttime can, send off that hormone that tells the kidneys to dump.
Right.
Kind
That's
of the same
right.
thing that happens when you get in a pool, because the
That's
compression on your body, the pressure. So
yes.
your kidneys, when you get out of a pool, you have to go to the bathroom and you go like
Yes. Yes. Yes.
crazy. Like, yeah, the same kind of thing. So there's a lot there, I think, for him, that if you get an opportunity to hang out with him a little bit more, to unpack around his sleep and see what's going on.
Yeah. I think also that's a great idea. Yeah, the CPAP was telling. I think he's in
Hmm.
his 40s. In terms for the listeners, just in terms of positioning, I think the supine position for me, I kind of get out of it fairly quickly unless they're really hot and aggravated. But I wanted to get him up into standing. I also got him on his just at the first session. I had him on his hands and knees just so that people know. And just to bear weight on the arms a little bit and just have him turn his head to the right, to the left, look down, look up, and just do some rocking back, just and try to get some head control. I mean, that's a really easy exercise to do. I give that all fours position, I would say, a lot to a lot of patients, no matter what diagnosis they have, to be honest, because I do
Hmm.
like that. It's fairly easy. So that's sort of hands and knees, a supine. I had him in standing. I'm just thinking of all the other positions, and then doing a lot of things on the Bosu ball. But you want to think about, his left scapular pain kind of went away. And so I actually think that was just probably incidental, or was obviously related, but I wasn't about to give him, I did not give him any kind of sort of push-ups on the wall, things like that, because I tested it at the beginning. I did the normal, narrow, wide.
Arms on the wall, right?
Yes,
Yeah.
yeah, I did that, and I just do a push up. Had my hands. I didn't really feel that was something he would be compliant with. I think in terms of exercise, you want to make sure that you give at least try to give them the things that they're going to be compliant with. And so,
And something
yeah,
that goes away that fast with just a bit of manual work that you did tells me it was probably just a little bit of a dermatomal issue from C2, C3
yeah,
into the left scapula. And that makes a lot of sense, because perhaps maybe his, not sternocleidomastoid, the other one, the one on the back, drawing a blank on the name,
rectus,
levator
elevator.
scapula, could have been, over recruiting in response to the information coming out of C2, C3. Because if he was not moving at C1, C2, and OA, like you were talking
No, he
about,
was very stiff there. Yeah,
yeah, then C2, C3 is where the pattern changes, and he was probably overusing that area, which could lead to some irritation, at the
yeah,
joint, and give you that kind of sclerodermal or neuro or myotomal, or even uh, nerve rooty kind of little bit, of sensory change through there that could be an irritant. And so once you got him moving a little bit better at C1, C2, he didn't have to over move at C2, C3. So,
exactly,
you know,
exactly.
mhm.
Yeah. and he was very hypertonic in all those muscles in the
Yeah.
posterior neck, and he from biomechanically, yes, he had a lot of restrictions, but a lot of that was like the main impairment was an overactive system. Period. End of report.
Yeah.
Overactive system. And but what I wanted to mention with him is because is a lot of people who have headaches, they tend to have overactive systems, but these headaches keep coming back. Okay. And is it related to exercise, or is it related to something else? And you have to make that judgment, and it's patient dependent. With him, I think it's probably multifactorial, not just sleep, a lot of other issues, but he does need to have good head control and control his head while he's moving and exercising. So for those patients, I do need to think that we do need to keep them on just a little bit longer, because you need to be able to give them good head control while they're moving, because they will just come back again for headaches on an as needed basis, and that is not good for them, I think in the long run, because there's so many people who do have chronic neck pain, or chronic headaches without any sort of sinister cause, right? And a lot of it is an overactive system, but at the expense of what? Are you using your neck muscles because your posterior chain is weak, because something, or is it because you just don't have good sort of tracking? That's the clinical reasoning piece. But you need, I don't think there's any wrong exercise to do with somebody like this, which is why I wanted to talk about him. But there has to be like a specific process that you're thinking about, and why are you giving this patient squats on a Bosu ball? Just because he needs to squat? No, because you want to challenge the balance, right, Susan? Like, right. So yeah, and so there has to be like, you have to explain this to the patient and say, your main, and I said your main issue is overactivity, but we need to sort of, you need to well, if it's an overactivity in one region, is there an underactivity somewhere else? Maybe. Is it a control problem? Probably. And I don't want to overthink this, but we often get these patients who we do manual work and they're like, great, I'm out of here, I'm good. Okay. And then they come back and they're like, oh, my headaches are back. And that's when I think you need to put your foot down.
Well, I think the biggest thing is that it takes time and effort to change the movement system, because you're asking the movement system, which is part of the sympathetic nervous system and part of that, if you will, older brain, and it just does what it's told. And so the brain responds to what the adaptations need to be and lays down a movement system for it. And if there's no reason to change it, it's not going to change. So the temporary piece of the manual therapy is great, because they do feel better, but for a little while. Because nothing's been done to allow that system to really do the work to change, and not have to go back to, okay, we're right back to standing the same way at work and over recruiting, so here we go. And so we want to give the system reasons and the ability to jump into a different movement pattern and not the same one over and over again.
And I think, just to finish up, I think that, if you are in a large clinic and you don't work with your patients in exercise, like you have somebody else do it, you need to train these people, because your patient's going to be out there doing a squat on a Bosu ball, or doing, on all fours, or on some Pilates equipment, doing some, even if they're doing a little bit of abdominal work, they're using head control, and you have an untrained person not untrained, but somebody who's not used to this, watching them, then they may as well not do it. I hate to say it.
Exactly.
But, you need to train your people. Because that's a waste of their time. So on that note, I hope you enjoyed it.
Yes. Yeah. Thanks for bringing this up. And I think we kind of talked about a lot of things that we have previously discussed in podcasts in a different way here. And we'd love your comments. We'd love to hear from you. Drop us a line, shoot us an email. We read every one, and we're happy to have you join us every other week for these fun podcasts. Thank you, everybody.